So this is a case which came to me in May of last year. This patient, his right eye was normal. His left eye had a mild decrease of vision to about 6-12 parts. And the fundus of the right eye was normal. The left eye, he was diagnosed with CSR. And he was having CSR for the last 2 to 3 months. His complaints were there for last 2 to 3 months. And it was not abating. Um, uh, and he was advised, because it was not resolving, he was advised injection of a anti-VEGF in that eye. The OCT had this picture. You can see a very classical CSR there, neurosensory elevation there in the left eye. The right eye is normal. So the question is, what will you do in such a situation? So I'll just go one slide ahead. And I did the FFA. And in the FFA, you can see, in the color fundus picture, you can see the area of the CSR. The right eye is normal. This is an artifact in the center. And on the fundus fluorescent picture, you can see a nice ink blot leak there. It is in the papillomacular bundle outside the foveal avascular zone. So what is to be done in such a situation?
You will have to only answer now.
I think I'll go, okay. So the question, yeah, this is the FFA, the further images of the FFA showing the leak.
Wait.
Okay, so should I wait?
I think
You should wait.
Wait, okay.
Our answer is wait.
So
That
this
was in
patient
fact
had
the
a persistent,
classical teaching, isn't it? That
pardon?
What was the classical teaching was that only? You did nothing about
No,
it.
Yes,
you
but
said
it was
it-
persistent for almost 3 months.
3 months.
3 months. 3 months.
was the age of the
Preetam.
patient?
Preetam,
Age of the patient?
The patient was 44.
44.
Yes.
Unusual age for this, and secondly, the other eye is totally normal.
Yes.
So, but is there a role for anti-VEGFs in
So that's
CSR?
what. So that he was advised anti-VEGF elsewhere and sent
Yeah,
to me.
but I think that's definitely not indicated.
Absolutely.
And
absolutely.
if at all, and it's not a lesion involving the fovea, it's actually in the paramacular area, though it's on the papillomacular bundle.
Yes.
So I would, you say it's just 2 months, other eye still has good vision. But still give it a month or two, just
Okay.
wait, and then maybe 4 months, 5 months down the line, if he's still having a problem, then maybe do a laser ablation for this.
Okay. So this
no,
patient
no,
was.
Preetam, in this, why not? Because it's away from the center. So not the photocoagulation, but the photo fomentation can be done, so at least that enhances the absorption of fluid, these subretinal fluids in these
Okay.
situations.
Okay. So this patient, he was
हर
44
चीज
years
ज़्यादा करते हो आप.
Sorry?
Is there, she's 44-year female.
Yes.
Is there any...
No, male patient.
Male patient. No, no, is there any precipitating factor, like due to some stress?
His wife.
Some stress. Which is causing the persistence, like some
Yes.
maybe
So
lost the job.
yes,
or
sir.
maybe
So
some
that
other
he
problem.
was a type A personality, an executive, and his main issue was he had problem driving at night. Now this has been persistent for about 2 or 3 months, and it was interfering with his driving. That was his problem. So I think I'll go ahead of what I did. So I did a focal laser in his eye, and his couple of weeks later, 5 weeks later in August, his vision had come back and the CSR had resolved. So you can see the picture here when he presented to me, and it has completely resolved over there. So coming to the points here, I think anti-VEGF is definitely not a treatment option for CSR, although there have been anecdotal reports where people have used it for chronic CSR cases, but that is not the gold standard of treatment for CSR. Focal laser is, yes, before focal laser, if the patient is a treatment naive patient, has come first time to you, then these CSR, they respond spontaneously very well. Almost 50% of them resolve spontaneously. So you prefer to wait. But here was a patient, a young patient, who had problems in his day-to-day, in his important activities in his life. So I chose to treat this patient. I chose focal laser. Although the leak here is in the papillomacular bundle, there is always an option of doing a low fluence photodynamic therapy in cases like this. And I've just shown 2 cases where PDT has worked wonderfully well. This is a case where you can see this leak over here, right at the fovea, and following PDT. This is 2 months post PDT. You can see the leak has gone and has left hardly any scar over there. And this is almost 2 years post treatment. There's one more case, pre-PDT, again a leak juxtafoveal very close to the fovea. Here you are scared doing focal laser because you would leave back a very bad scotoma if you're lasering. Although even when you're lasering, doing a focal laser, you're supposed to use very light burns, but you could still leave back scotomas. So this is another case where PDT worked beautifully well, and it resolved. Of course, it has left back some RP alterations because of the CSR leak. So this was a case of CSR. I have one more case to show here, and again, that is
Your
something which we
take-home
commonly
message is, if it is in the, if it's a persistent CSR, if it's in the foveal area, then do a PDT, and if it's in the paramacular, go ahead and do a focal laser.
Yes.
These are the only two.
Yeah.
And
So the
I
treatment
think,
algorithm
no.
would be that if the patient is presenting for the first time, you observe, wait and watch for maybe 2 or 3 months, and when you have to treat it, if it's away from the foveal avascular zone, especially temporal to it, then focal laser works beautifully well. And if it is very near to the fovea, a low fluence PDT can be done.
I think the important message is that, because nowadays there's a tendency for excessive injections of anti-VEGF.
Yes.
There's absolutely no role for that
No
in this
role.
situation.
Yes.
Okay.
Can I, on the CSR case, patient came to me, diagnosed CSR. I charged him the consultation. I said, wait. He came next. I said, okay, you are not happy. I sent him to the retina specialist. He charged 900 and he said, wait. What the patient should do, or what the
Send to me, I'll charge
ophthalmologist-
1800.
Poor patient.
Thank you. Next case.
So the next case, it's that what we most commonly see in our retina OPDs, that is diabetic retinopathy. So this was a 43-year-old male, a phakic patient, known diabetic, hypertensive, and the fundus picture was that of diabetic retinopathy. Right eye vision was 6/9 and 6, left eye was 6/60, and he had left eye was severe NPDR with diabetic macular edema. And again, he was advised injection Ozurdex. Now, mind you, this was a treatment naive patient. He had not taken any treatment before, and he was
Photo nikalna hai, 2 minutes.
advised injection Ozurdex. And this was the picture. This is a fundus picture, the FFA and the OCT. You can see the the diabetic macular edema, the hard exudates. On FFA, you can see the leak here, and OCT is showing a nice spongy diabetic macular edema. So, what will you do in such a case? Now, we have a huge plethora of treatments for diabetic macular edemas. He has already been advised Ozurdex, but you also have anti-VEGFs, and what is the role of macular laser in these cases? So, what we offered, we saw that the patient again was 43-year-old. He's a phakic patient. So, instead of Ozurdex, I chose to inject this patient with anti-VEGF. So, and there was a cost issue here. So after having explained the patient about the off-label nature of bevacizumab, we gave the patient 3 injections of bevacizumab over a period of 3 months. Following that, in the next 6 months, the patient required 2 injections and some rescue laser, focal laser. You can see the laser burns. But following that, over 9 months, he has responded very well. You can see the edema has come down. The patient has improved vision by about 2 lines. And you can see the OCT also showing improvement in the macular edema. So I'll just go, the routine algorithm, a simple algorithm which I follow when I see diabetic macular edemas are, if it is a non-center involving diabetic macula, a focal, what we call as a focal DME, then you really don't need to inject these cases because the fovea is dry. These patients usually have good vision, but you have to, if it is in the vicinity of the fovea, if it is a clinically significant macular edema, you didn't need to treat it, and there laser still is a gold standard, so laser does work in such cases. If it is a diffuse center involving diabetic macular edema, then you have the choice of giving injections. You should be giving injections, and then you have to you choose between an anti-VEGF and a steroid. In patients who are phakics, young patients, anti-VEGFs work beautifully well. And those patients where the diabetic macular edema is more of a chronic nature, where the patient is probably pseudophakic, elderly patient, a patient has systemic comorbidities where you don't want to give anti-VEGF because the patient already has ischemic heart disease or the stroke, history of stroke, there you would then choose steroids, either triamcinolone or Ozurdex. And the last scenario, if you have a diabetic macular edema with a vitreomacular traction, then you need to go for vitrectomy.
Thank you.
Thank you.